Philadelphia International Medicine, PIM, provides international patients and physicians with access to an unmatched network of world-renowned doctors, surgeons, and hospitals that deliver personalized medical, surgical, and rehabilitative care ranked among the best in the world. Since 1999, Philadelphia International Medicine has helped patients and physicians from around the globe eliminate the guesswork, planning, and anxiety of finding and connecting with doctors and hospitals ranked among the best in the world. With 8 hospitals, 2 medical schools, 2 cancer centers, and hundreds of top doctors, only PIM can bring you into its medical family with one easy phone call or email. Thanks for joining our presentation. Philadelphia International Medicine's Global Education Media Program is a monthly digital platform that invites physicians from around the world to exchange knowledge and innovative uses of medical technology, review the latest advancements in research and clinical care, and share best practices in case reviews. To contact our presenter, refer a patient, or more information, email physicians@philadelphiamedicine.com. Follow PIM's YouTube channel for more educational videos.
Nevertheless, I'll be talking about Monteris's product called Neuroblate, and that is one of the 2 laser devices on the market here in the United States. So that presently we perform craniotomies to resect brain tumors, which you can see in the upper left, where we are resecting a tumor from this patient's brain, and now we have a nice clean resection cavity in the lower right. And this is a maximally invasive approach. It carries with it risks of bleeding, infection, seizure, and so we're always looking for more minimally invasive treatments for these tumors. Now, unfortunately, Star Trek and Dr. McCoy and his scanner has not yet been developed to diagnose and cure patients' diseases. And the future of neurosurgery, people have looked at holograms. That's actually not too futuristic. There are companies developing holograms to create 3-dimensional reconstructions of the brain so you can see in a more realistic 3D fashion the exact location of tumors. Thus far, the practicality of this hasn't really played out. There's always robotic surgery. And again, this picture is from a movie. We're not quite there with the robotic surgery, but things such as the Da Vinci have been used with limited effect so far. So that everyone's watching us to see how this is going to play out. And what's called laser interstitial thermal therapy, which is the generic name for laser ablation therapy, or LIT, has started to be developed back in the early 80s, as you can see. Brown published an article where he used a YAG laser and was able to cause cytoreduction of tumors or debulk a tumor, but this was under direct visualization. I know when I was a resident back in the 80s, we played with all kinds of lasers, each one for about 6 months, and then they were pushed into the corner and collected dust. Lasers have since developed a much more substantial role in the fields of ENT and dermatology, but in neurosurgery, they really never took off. So there were subsequent publications where other investigators used lasers to try to either create functional lesions for controlling movement disorders or Parkinson's disease, or removal of tumors. But again, these were very scattered and not very consistent. Several of these were published in the literature. And our colleagues from Germany were able to show how they could laser a recurrent glioblastoma. And you can see the laser tract in the top middle picture here. And then they followed this patient very closely. But as you can also see, they only treated the one lesion in the back. There were scattered other multifocal lesions. And ultimately, the laser controlled a portion of the tumor, but not the whole tumor. So there's no standby or effect with this. Now, the big change with lasers was that in the mid-90s, DePorter and his group were able to create the ability to do real-time thermal imaging. So that before you stuck the laser, it's actually a fiber optic cable that you use that you attach to a laser device, and you stick the fiber optic cable into the tumor, and then you treat away, and then at some point you stop treating. But you don't know, there was no way to identify the extent of treatment. Now, DePorter has developed this software that can do real-time thermography from an MRI scan. And that really opened the door for today's lit treatments, because now you could actively follow in real time the extent of disease, of destruction. Because ultimately, laser works by cooking the tissue. So we're cooking the tissue from inside out using a fiber optic cable to transmit the heat from the laser into the tissue. So the French were able to perform the first treatment using this real-time thermography, and they had very positive results, especially since it's minimally invasive. Now, for recurrent glioblastomas, we have limited options. You can do another craniotomy, you can do a radiation boost. There are always chemotherapy trials, clinical trials, but now we have added the lit therapy. But this is not just for gliomas. Lit has been used for upfront treatment of gliomas, in which you do a stereotactic biopsy and then immediately follow that after getting frozen section confirmation with the lit treatment. You can do it for recurrent gliomas, also for treatment of brain metastases, both upfront and recurrent. We've used them to treat meningiomas. A colleague of mine has started treating some cavernous angiomas, and that makes me a little nervous, sticking a fiber optic cable into a blood vessel. But thus far, he's had some pretty good results without significant bleeding. And then a big area of utility is symptomatic radiation necrosis. Radiation necrosis is not just dead tissue, it's actually an autoimmune phenomena, wherein the nidus of the radiation necrotic tissue creates this immune response, and that's why in some patients, this takes off. You get profound edema, swelling of the tissue, mass effect that you cannot control with just steroids. One of the treatments for that would be surgery to go in and debulk the radiation necrosis. And those of us in the brain tumor world know that this will nicely reduce the effects of radiation necrosis and frequently stop it. But now we have this minimally invasive approach with the lit that can do the same thing. So that lit delivers laser energy through a fiber optic catheter directly into the tissue. You get the laser energy is absorbed and heats up the tissue, and it functions in a cytoreductive fashion, much like surgery, because the tissue is now totally destroyed, it's killed, and we'll have a little more to say about that further on, where we can actually monitor the degree of injury of the tissue. So it can be used in patients who aren't candidates for open surgery. It's certainly less invasive and causes minimal injury to the surrounding tissue. In many cases, the patients will go home the next day. So it's a very short hospital stay. Unlike radiation, it's not cumulative, so you can do as many treatments as you need. And then you can always follow to radiation and chemotherapy, especially for newly diagnosed patients. You don't have to wait for the wound to heal. They can start radiation chemotherapy literally the next day, because it's a very small incision and just a small 4 to 5 millimeter hole in the skull. So that there are a couple different types of treatment tips. And this is dependent on the company. There are 2 companies here in the United States that are FDA approved. One is a device called Neuroblate from a company, Monteris. And Neuroblate has 2 separate tips. One is the side fire, where the tip of the fiber optic cable is coated. And then there is a slit made in the coating, and that's where the laser energy escapes. The intent here is to make it a more directed laser. The reality is it's not as directed as you would like. The other is what's called the full fire, where the tip of the fiber optic cable is uncoated and the laser energy comes out of the tip of the catheter and creates kind of a rounded teardrop lesion. The second company is Visualace, and they were recently bought by Medtronic. They have only a full fire type tip. Their technology is a little different, so there's a difference in the technology, but the end result is that these companies both deliver effective laser energy into the tissue to create lesions for functional neurosurgery and also for destruction of tumors. So this is a schematic of the patient in the MRI scan. Unfortunately, we can't get pictures in the MRI scan because the magnetic field destroys the cameras. But the patient's put into the MRI scan. We have a head coil that's put around the patient's head. And then we have attachment here. This is, and again, I'm going to talk about the NeuroBlate system because that's the one I use and know best. But all these concepts translate over to the other system because they're very similar. So we make an incision, we put a 4.5 millimeter twist drill hole in the skull and then attach this little metal mini bolt, it's titanium. And then here is the laser device with a robotic attachment so that this fiber optic cable can be moved both in and out of the tissue and rotated circumferentially if you're using a side fire. The Visualace system, again, attaches to a bolt attached to the skull, but it's manually driven, so you have to go into the scanner and move it in and out. So this is the operating console. On the top left is a tripod device that was initially developed by NeuroBlate. Some people are still using this. I've gotten away from it. It's a little cumbersome. But what you see here are the real-time MRI images. So the MRI scanner is constantly running while the patient, during the treatment. And so here we have two coronal and a sagittal view showing the fiber optic cable coming down into the tumor that for illustrative purposes has been colored green. So you can see how the catheter comes right into the tumor. And here on the monitor, we have the crosshairs showing us the location of the tumor. So we want to make sure once the fiber optic cable is put in, there are a lot of checks and balances that are performed to make sure that we're accurately looking at the fiber optic cable because we need to know its exact location within the patient's brain. So here's, again, a schematic showing the fiber optic cable going into the tumor. And A shows a nice vascular tumor. B shows where we're starting to cook it here on the side. This is a side fire. And then here shows it cooked. Now the NeuroBlate heats tissue up to 43 degrees Celsius, which denatures all the proteins and essentially kills all the tissue. So that when we're doing the treatment, we follow what's called the thermal damage threshold, the TDT, and there are a couple of options on the software. The blue line shows what represents tissue that's been treated to 43 degrees Celsius for 10 minutes. And in this case, no tissue survives. The yellow line shows tissue treated to 43 degrees Celsius for 2 minutes, in which most of the tissue is killed, but some may survive. And then the white line, I don't know why the company put this on there. Nobody uses it, but it's equivalent to 43 degrees Celsius for 30 minutes in which the tissue is totally vaporized. But in reality, we use mainly the yellow line and sometimes the blue line. And I have a short video that will show how, once we start the treatment, this TDT line will start to expand to cover the dimension of the tumor. In fact, here's the video. So what we're looking at here is the tumors outlined in light blue, Here's the catheter put in. Here you can see this has been sped up. You can see the yellow line, and we go back and forth to the blue line. And what we just did with that blip was we pulled the catheter back a little bit. So we treated the depths first, and now we're treating, and you can see it best on the bottom, the coronal and the sagittal views on the bottom, how we build these burns on top of each other. And you can see we just flick to the blue line, and you can see how with the laser on, it expands and covers the dimensions of the tumor. Let me show it one more time for you. So the goal here is we manipulate the fiber optic cable so that we start at the depth of the tumor and gradually back our way out. And then in a tumor such as this, where we may not be getting the anterior portion, we will have planned a second trajectory that will come down into that portion. So we use the first placement to treat as much of the tumor as possible, and then a second trajectory to take care of any of the edges. So this is a patient of mine who had a glioblastoma that recurred 18 months after treatment. You can see it's a small recurrence. The guy was in excellent shape with a Karnofsky of 100, working full time, and so he elected to go ahead with the treatment. So we did the lit treatment, and you can see now how the tumor has this bland, light gray ground glass appearance to it. We had an excellent treatment for his. Unfortunately, his tumor was more aggressive than we thought, and it came back. It had actually transitioned from a glioblastoma to a gliosarcoma. And so he still survived quite a long time, but I reoperated on him. This is a college professor who presented with this massive thalamic glioma. We decided it was not resectable. She had seen a couple of neurosurgeons who all agreed. So we treated her with a lit, and you can see how all of the central tissue has been destroyed. You can see the thick enhancing rind of the tumor is now greatly thinned out, which is what you see from any lit lesion. So we had an excellent treatment there. She then went on to chemotherapy and radiation within less than a month. And she survived with this tumor for more than a year. This is a patient from one of my partners who has a multiply recurrent atypical meningioma. So we can treat meningiomas too. It's not just gliomas and metastatic tumors. And so on the top line is the recurrence. As you can see for meningioma, this is very deep in the brain. Typically, they would be out on the cortical surface. So I treated her, and you can see how it caused all these cysts to form. And she actually did very well. But her tumor, unfortunately, there were deeper portions of the tumor that were very aggressive and came back about a year later or so. But we bought her a lot of time with that treatment. This one was a real technical challenge. This 84-year-old woman, who was not a good candidate for surgery, had metastatic breast cancer, and you can see it on the inferior aspect of the left tentorium here. She had had surgery. She had I think 2 rounds of radiosurgery. She was having some problems with the radiation swelling, and then the tumor was growing back. So I was able to attach a bolt down way low on the base of the skull and angle it just so that it came straight up underneath the tentorium. And you can see the lesion here. We actually got a very good lesion for her. And now here at 3 months post-treatment, you can see how the lesion cavity is shrinking down. And she did well with no recurrence of that tumor. So we can get to some more difficult places in the brain too, including infratentorial. To the best of my knowledge, nobody has lesioned the brainstem mass yet, but many cerebellar tumors have been lesioned. This is a patient who had radiation necrosis from, again, multiple radiation treatments for a colorectal metastasis into the right parietal region. You can see on the top row the thick rind of enhancing tissue from the radiation necrosis. And there was massive edema throughout the right parietal lobe extending into the occipital and frontal lobes. So we treated her, and it's very nice. In the bottom row, you can actually see the two catheter tracks, one here and one there. I placed two catheters into her head. And with radiation necrosis, you don't have to remove all of it or lesion all of it, but you want to get most of it. So you can see on the upper images, we got all of it with these two tracks. Here we got most of it as we did here. Now the beauty of radiation necrosis is that these patients respond very quickly. Typically, when you get a good treatment for a patient with radiation necrosis, their symptoms are improved within 24 hours. I've had patients tell me they were better than that night following the treatment, and certainly by the next day they notice improvement, which is very dramatic. And I must say, I didn't expect to see it happen that quickly. You know, there's a lot of good things with LIT, so here's one of the bad things. There's always a learning curve. This is a gentleman who had a small brain met from his lung cancer in the left tentorial region. So we put a catheter in, we got a nice treatment. This was the next day after treatment. But the next day he was complaining of hearing loss in his left ear, and he had a facial nerve palsy. What we failed to do was look at the lower down on our imaging, which was, again, limited. It was cropped. But here is his internal auditory canal. And so the thermal heat was conducted through this layer of bone in the temporal bone and got into his internal auditory canal. And unfortunately, the heat also damaged his seventh nerve, his facial nerve, and his eighth nerve, his auditory nerve. Now, he has since got some hearing back, and his facial palsy has improved, but he's not returned to baseline. The tumor has not grown, but he has not gotten back to his baseline. So a group of my colleagues got together and pulled their data, and they showed 34 patients with what they described as difficult to access high-grade gliomas. So 24 of them were glioblastomas, 6 were anaplastic astrocytomas, and 4 anaplastic oligodendrogliomas. They treated 16 of them up front with LIT, and then 19 were treated later on for recurrences, and followed these patients and collected their data. These are just the demographics, which, you know, none of them were statistically significant. So that overall, there was a progression-free survival of 5.1 months. And again, a lot of these were recurrent tumors. Median survival had not been reached at 1 year. So that they went back and looked at the yellow TDT line, and those that had coverage of all but 0.05 cubic centimeters had a median progression-free survival of 9.7 months. And those with greater than 0.05 cubic centimeters had a median progression-free survival of only 4.6 months. So you can see the breakout there where you double the progression-free survival. And with the blue TDT line, you see the same fallout. So what this shows is that you need to treat the whole lesion in patients with active malignant gliomas. Again, this is just a graphing of the favorable treatment line versus the unfavorable treatment. And there are many reasons why you can't get a favorable treatment. One of the things that we have learned is that we're destroying tissue with heat. And much like an automobile engine creates a lot of heat but it has a radiator system that circulates coolant to cool off the engine. Well, in the brain, we have spinal fluid that does the same thing, so that tumors that are near the ventricles or large CSF spaces or a large resection cavity or a large blood vessel, the blood in the blood vessel and the spinal fluid will act as a heat sink and prevent you from adequately generating enough heat in the tissue for treatment. So we've learned the tricks are that you place the catheter right next to the heat sink and then fire away from it so you can generate heat into the tissue where it's not getting absorbed by the spinal fluid. There are also some tracts in the brain that are densely packed that tend to be resistant to radiation. So the densely packed white matter tracts tend to be a little more, not resistant to radiation, but resistant to the heat propagation. For instance, when we treat patients for radiation necrosis, the temperature just flies right through the tissue, and those treatments are very quick. So for densely packed tumor tissue, it takes longer to treat them. My colleague, Shabar Danish, who is up at Rutgers Medical College in New Brunswick, New Jersey, has worked with his radiologists, and he's done some fascinating work looking at MRI markers associated with response to lit. They create these checkerboard paradigms, and then they can match up different tissue sequences and create these very interesting graphs to be able to, in a prognostic fashion, determine what part of the tissue is going to respond to treatment and what's not. And then you can determine whether you need to retreat them or go to something like stereotactic radiosurgery or something as simple as start chemotherapy more quickly instead of waiting for a recurrence. So this is very, go back a second, this is actually very dynamic information, and if this is confirmed, this will enable us to, with simple imaging, be able to follow these patients and determine those that were adequately treated, which parts of the tumor were adequately treated, and then be able to manage the part that was not adequately treated in some additional fashion instead of waiting for the patient to have yet another recurrence of their brain tumor. So that LIT achieves actually a resection of the tumor because we're destroying it. The only difference is we're not taking the tumor out. The tissue gets left in place to necrose and degrade and disappear. We are able to resect deep-seated resectable tumors. We've also treated butterfly gliomas, where you put catheters on both sides of the frontal lobes and bring them down into the corpus callosum. Those are very interesting cases. In general, the patients have a shorter length of stay, and there is data to support this now. In many cases, they're discharged the next day. In the United States, the way to get a new treatment going is to have billing codes. You want to get paid for it. So the billing codes for this here in the US are the standard billing codes for craniotomy for tumor. There's a code for application of the head frame, for stereotactic navigation, and for open procedure in an MRI scanner. You can also add on stereotactic biopsy if you do a biopsy at the time. Now, these procedures, the actual laser treatment is done in the MRI scanner, but only a handful of my colleagues have intraoperative MRI scanners. So that what we do is we take the patient to the operating room. It's done under general anesthesia. The stereotactic coordinates are lined up. The mini bolt is placed in the skull, and then they're taken downstairs. In my institution, the MRI scanners are in the basement, and we take them downstairs and attach the laser to the fiber optic cable, or place the fiber optic cable, attach the laser to that, and do the treatment. So these are all done in MRI scanners, and they're done in diagnostic scanners for the most part. You need to be able to schedule a couple of hours for this treatment in the MRI scanner. So the radiologists don't like you because it clogs up their scan. But the reimbursements are very good for this, so that they're happy when they get paid. Certainly, it's a lot easier and quicker if you have an intraoperative MRI scanner, but they're expensive and not everybody can afford them. And so these are some of my residents that have helped me with this, put it together. And thank you for your attention.